I think Dr. Nida Khan is ready. So she will be presenting on long-term ocular complications of Vogt Koyanagi Harada disease, a study at a tertiary eye care center.
Good afternoon, everyone. Today I will be presenting on long-term ocular complications of VKH disease. VKH is an autoimmune granulomatous disorder which involves T-cell mediated autoimmune dysregulation targeting melanocyte self-antigens. It's lead to vision and hearing disturbances. Ocular manifestation is characterized by bilateral granulomatous uveitis associated with serous retinal detachment. Till date, very few studies have evaluated long-term complications in VKH. A study evaluated ocular and extraocular complication with a follow-up duration of more than 6 months of the initial diagnosis of VKH disease. Another study evaluated ocular complication at the time of presentation. However, the purpose of this study was to evaluate the spectrum of long-term ocular complication in VKH patient observed after a follow-up period of more than 3 years at a tertiary referral center. This was a retrospective observational study conducted between 2015 to 2020. Analysis of electronic medical records of newly presented VKH disease patients with a follow-up duration of more than 3 years was done at a referral clinic. The study included 122 eyes of 61 patients with 16 males and 45 females. The mean age at diagnosis of disease was 36 years. The mean duration of uveitis from the onset of symptoms was 6 months. The most common immunosuppressive drug given to these patients was azathioprine followed by mycophenolate and then a combination of azathioprine and cyclosporine. Most common ocular complication which we encountered was cataract followed by ERM, glaucoma, posterior synecdoche, retinal detachment, CME, subretinal fibrosis, CNVM. The most common extraocular manifestation was meningism in this patient followed by hearing loss, vitiligo, tinnitus, alopecia and poliosis. Most common complication with steroids was glucose intolerance followed by hypertension, osteoporosis. One of the patients developed avascular necrosis of femur head. Most common complication with a steroid-sparing agent was bone marrow suppression followed by hepatotoxicity. One patient developed tuberculosis, another developed oropharyngeal candidiasis, one patient developed reactivation of herpes zoster, and another developed GI infection. 39 eyes required required cataract surgery. Vitreoretinal surgery was required in 5 eyes and TRAB in 3 eyes. Intravitreal anti-VEGF had to be given in 10 eyes for CNVM and 7 eyes required intravitreal steroids. Post-treatment, the visual acuity improved in 61 eyes. It remained same in 33 eyes and it worsened in 28 eyes. VKH is usually diagnosed at the age of 20 to 50 years. It is frequent in pigmented races and females have a slight predilection. In the present study, the mean age of diagnosis was 36 years with 16 males and 45 females. In the present study, majority of the eyes, that is 94.3% of eyes, developed some ocular complication after a follow-up period of 3 years. It is consistent with the finding involving 18 VKH patients in which 83% of the eyes developed some ocular complication. Cataract was the most common ocular complication encountered in our study. It is comparable to a report of 101 VKH patients that showed cataract being the most common ocular complication in VKH patient. This is a photograph of one of our patients of VKH disease showing circumciliary congestion, granulomatous capes, iris nodules, and complicated cataract. Meningism was the most common extraocular symptoms followed by hearing loss, vitiligo, tinnitus in our study. It is comparable to the findings of Monker et al. On Indian patient in which meningism was the commonest extraocular findings followed by auditory disturbances. In our study, all patients required immunosuppressive therapy. Azathioprine was the most commonly used one. However, only 39% and 16% cases required steroid-sparing agent in a study by Monker et al. And Potapova et al. Respectively. This is the OCT image showing bacillary layer detachment and urothelial detachment before and after treatment. All of this was resolved. Surgical intervention was required in 39% of the eyes in our study. This could be due to the long duration of follow-up of 73 months in our study that majority of the patients acquired some ocular complication which was the need for surgical intervention. However, in a study with a duration of 15 weeks of follow-up, only 7.6% require some surgical intervention. Following treatment, the vision improved in 61 eyes, remains in 33 eyes, and it worsened in 28 eyes. The worsening of visual acuity can be attributed to various ocular complications. This is the ICG image of one of our patients showing reduction in number of hypofluorescent dark dots after treatment. To conclude, majority of the eyes develop some ocular complication after a follow-up period of 3 years. Dose-limiting complication developed in 34% and 26% patients with IMT and steroids respectively. Early diagnosis and prompt treatment of VKH with steroids and IMT can preserve vision and delay development of complications. Dose-limiting complications of steroids and IMT can be averted by timely adjustment of dose and replacement with other agents as required. Thank you.
See, it's a nice paper. It's just a comment that I'm making. I just thought of it while you were presenting. The Monkar et al. Paper that you are quoting here is a 2000 paper.
Yeah.
Yeah, and it's from your institute only.
Yeah.
So you are saying only 39% required immunomodulation. I think back then we weren't probably using immunomodulation so much. What I'm trying to say, it may make sense that you compare this data with the data which was used for that study and see if outcomes are now better with with better use of immunomodulators. I think that that would be a very pertinent thing. Another just very random thought that came to my mind, and there are other uveitis specialists here, so I would like to know their opinions. One patient has developed avascular necrosis of the femur. How many of us here are using bisphosphonates weekly in these patients in whom we are using steroids? Because our neurology counterparts, because I work even as a neuro-ophthalmologist, they use weekly bisphosphonate as soon as they put the patient on even 60 milligrams of Wisplon. So I think that would be a good idea, because we tend to use steroids longer than they use. Because yeah, so as soon as they write 60 milligram Wisplon, they will write Osteophos 70. And they use it, and I talk to them, and they are as if it has to be used. It cannot not be used. I mean, so for quite some time now, I'm thinking that that should become a part of even our regimens. Because AVN is a devastating complication for them. It's just that one fine day they will have something and something will happen. Yeah.
They were talking about the HBS status for before starting steroids.
Yeah.
I think the protocol revision will also have to look at adding bisphosphonates there.
Yes.
Like I mean, I'm just telling the protocol needs to be revised.
Yes.